and welcome to the Home of Medicine podcast. This is a new podcast from the European Federation of Internal Medicine. I'm Amy Burbridge. I'm a consultant in acute and internal medicine working in the UK. And each episode, I will be joined by guest presenters from all over the world. The focus of the podcast will be solving clinical conundrums and clinical reasoning. And there'll be some all-important and my personal favourite, physiology thrown in. This week, I am joined by
Steve Laird, a consultant medical microbiologist working in Coventry and Warwickshire in the United Kingdom.
Fantastic. Thank you so much for joining us today, Steve. And we're going to work through a case. I know nothing about this case, so I'm going into this completely with lack of any knowledge. So, Steve, over to you.
Thanks, Amy. Amy, this is going to be a great case because there's a huge amount of learning and loads of red herrings. So please forgive me if I steer you down the wrong way. Okay, so basically this is a 63-year-old lady who's presented with 8 weeks of fatigue, crippling fatigue at the end, but quite indolent fatigue right at the beginning of the time in which she started to become symptomatic. So I know you love your cognitive bias, and I know you know that I'm an infection specialist. What kind of things are you thinking about with regards to this 63-year-old who's got fatigue and just fatigue?
So no other symptoms at the moment at all that she's mentioned. It's just the fatigue.
It becomes apparent once you start probing. You do get you definitely do get more symptoms out of her, and with the help of her daughter, which shows that the collateral history is important.
Okay, so if I've just got fatigue, that could be absolutely anything or everything, to be honest. Because I'm being presented this case by an infectious disease consultant, and obviously you're right, there's a huge amount of biases that go into any clinical decision making. And that goes even down to the basics of who's presenting the case to you. So an infectious disease specialist, I'm thinking 8 weeks fatigue, Lyme's disease.
Yeah, Lyme disease. There's no S in it. It's the place in Connecticut.
Okay, yeah, so Lyme disease. And because it's been such a long amount you're thinking like affective endocarditis, because that can be quite indolent. It can lead to fatigue. It's unlikely to be one of the more acute sort of tropical diseases, and to be honest, I don't really know anything about her travel at this stage. I don't really know enough information, so I'd like a little bit more if that's okay.
Yeah, no, absolutely, and that's what we did too. So the lady was 63-year-old, and she presented with this fatigue, which started off very slowly and then got to a point where she just couldn't feed herself anymore. She was so tired. Her daughter was becoming worried that this was depression and that this was all apathy rather than being true fatigue, that she just didn't want to. She was lonely. It was lockdown time. She was getting worried. So she said, right, enough's enough. I'm going to go and take her to the GP. The GP, when he had a conversation with her, actually did an examination and found out that she'd spiked temperature at surgery. So now we have a temperature of 38.2. And which had just happened. He'd done 2 temperatures there before, completely afebrile at 37.4. Then she spiked a temperature. And actually, watching this lady walk, it wasn't just the fatigue, it was actual true shortness of breath. This lady was short of breath walking in and out of the GP surgery. The chest was clear on examination, but now we've got 3 actual, we've got a symptom and we've got two elicited signs. So we've got a little bit more. The past medical history of this lady is very interesting, or it's very appropriate. She's a lady who had rheumatic fever as a child. She also had heart disease because of that. Her kidneys are completely fine. And as we know from rheumatic fever, it's not just about the streptococcal infection that you have at the beginning, but it's also about the immunological complexes that we get later on, causing damage, structural damage to the heart valves, especially mitral stenosis being the most common, and the kidneys having immunocomplexes in there. So kidney's normal, but she does actually have ongoing worsening mitral stenosis, and she has very bad incompetence of aortic valve. This, however, was sorted out in 2010 when she had 2 valve replacements. She had biprosthetic valves.
Okay.
So now we've got 10 years later, almost, well, 11 years later, we've got an epithelialized prosthetic valves, which were pig. One of them might be okay, one of them might be not. But what are we thinking now, Amy? I've given you a bit more information, the information I didn't have when I had this referral.
Okay. Again, there's still a huge number of more questions that I'd really like to ask for the history, but I know that that's not possible at the moment. So she's obviously spiked a temperature, 38.2. That doesn't necessarily mean there's an infective process going on, but it indicates that there's an inflammatory process going on. There is some cytokines being released, swimming around the system, and we know that there's some immune complex formation. You said that she was short of breath and fatigued. This happened during the pandemic. Did she have COVID? Could this be long COVID? This is something that I don't know from her past history. Because of a history of rheumatic fever, we know that she's had previous heart valve surgery. Could this be infective endocarditis? Because we know that she's got a temperature, we know that she's had prosthetic valves and previous rheumatic fever. So she is probably in the at-risk category for infective endocarditis. So that's something that I'd also be thinking about as well.
Okay, so the GP had listed that this lady's been double vaccinated and that she's had very little contact with a lots of people, so a less risk for getting COVID. But it's pandemic, it's endemic at the moment, so it's still a risk. He was worried about this as a primary diagnosis. So actually, because of how short of breath she was when she got to the end of the consultation room, was sent into hospital, and that's where we saw her.
Okay.
So her COVID test was negative.
Okay.
And with a little bit more history from the daughter, we found out that actually she'd been relatively well prior to that. She'd been eating independent. She didn't smoke. She didn't do any form of illicit drugs, and she wasn't drinking anything. Truly in her heart, she didn't think that she had any form of depression, and she hadn't started any new medication, or stopped any old medication, because this lady was on heart failure treatment. So going into potentially the early stages of heart failure, because stopping her furosemide or her perindopril or whatever she was on might have been a cause of this, but she hadn't. Nothing had really changed. She was just getting slow over the 8 weeks.
Okay.
Do you want to talk a little bit about the blood tests that we did, Amy?
Yeah, so first of all then, just to recap, we've got a 63-year-old lady with a history of rheumatic fever. She's had valve replacements, and she's presented with an 8-week history of fatigue and some shortness of breath.
Yeah, and an isolated fever.
And an isolated fever. Okay. Had she had a cough at all?
She had no cough.
No. Had she lost any weight?
She hasn't lost any weight.
Okay. Any sweats at all? Night
Not,
sweats?
She had 2 episodes which you could probably describe as rigors, uncontrollable shaking, which were lasted over a couple of minutes and then stopped. But this was two episodes in 8 weeks that she could remember.
Okay. Any rash?
Nothing at all.
Okay. Any pains in the chest at all?
No.
Any joint pains?
No joint pains either. A little bit of back pain, but when examined, that was just musculoskeletal. Nothing to worry about.
Okay. Any headache?
No headache.
No. Any visual disturbances?
No, not at all.
No. Okay. Any diarrhea?
No diarrhea.
No. Any nausea, vomiting?
No nausea or vomiting.
No. Okay. Any pains, any abdominal pain?
Which is a very good question, because that will come in later on, and it's something that I was keen to find out myself. No abdominal pain, especially right upper quadrant pain.
Okay. Any jaundice?
Yes.
She was jaundiced.
She was mildly jaundiced, very, very mildly jaundiced, and you really had to get her in the right light to be able to notice that.
Okay.
Yeah.
Had she noticed a change in the colour of her stools or urine?
No, nothing at all. She had no signs of an obstructive biliary infection. Not really.
Okay. Had she been on holiday recently, any travel abroad? I mean, I know it's very difficult because it is the pandemic still. So had she actually been anywhere?
You would not believe how many people come back from all over the place in this pandemic. So
Really?
yes, we definitely did ask.
Yeah.
There are people traveling everywhere, and if you think about it, there's sandflies in
Yeah.
Portugal, so there's potential of leishmaniasis there.
Yes.
But there's with so there was no travel history, and remember, just because this lady's in her 60s, there's absolutely,
Ah,
if you're thinking it's weird and wonderful, a sexual history is not
yes.
unreasonable either.
Yeah.
Um, on this occasion, it was mildly touched upon. It wasn't because it was less relevant
Mhm.
than some of the other cases that are that we do need to go into sexual history.
Mhm. And I think that highlights another cognitive bias is that we've talked about it quite a lot with doctors at work, that actually people, it doesn't matter what age, are sexually active.
Mhm.
And it's really important to get a thorough sexual history. And it is challenging sometimes to take, and it can feel a little bit uncomfortable. But actually, I've never had a patient say to me that they didn't want to talk about it. And the first question that you can start with is, are you sexually active? And it's also important to find out, if they're not sexually active, when they were less sexually active. Was it 2 weeks ago, or was it 2 years or 20 years ago? So it's about clarifying the timeline as well. And that's really important.
And I think what goes with that is sometimes it's not just talking about the sex, but it's actually talking about the organs themselves. So yes, we might talk about sexual activity, and someone might turn around and say, well, no, I don't have sex because it really hurt, and it's just felt uncomfortable in the last couple of months when I've been bleeding more. And it's
Mhm.
62, 63, I'd be very worried about that.
Yeah.
Has this person become fatigued because they've got a vulval cancer?
Yeah.
And it's the same with breast examinations as well,
Mhm.
and genital examinations on men. We
Mhm.
shouldn't shy away from that. If we've
Yeah.
got a scenario like this, where someone's just become fatigued and
Mhm.
listless for a long period of time, we
Mhm.
have to think about cancer as one of those things, and we
Yeah.
have to make sure that we examine everyone.
Absolutely. And I think that raises another point as well. We have just been discussing infection here, but also you brought up malignancy. Obviously, other conditions that can also cause these symptoms are the vasculitides, or the thyroid abnormalities, or other endocrine abnormalities. So the list is actually quite long. And I guess that's where our history, examination, and our investigations are going to really try and nail down which organ is being affected, and also, is it vascular, is it infective, is it malignant, is it endocrine?
And sometimes Occam's razor usually leads to one diagnosis, but
Mhm.
sometimes you will get somebody with a biliary sepsis because they've got an obstructive cholangiocarcinoma, and they might be picked up at the same presentation. So
Yeah. And that's Hickham's dictum, isn't it? A patient can
mm.
have as many diseases as they damn well please. And I think that's really, it's, often we get to that one diagnosis, and it's called search satisficing. It's another type of cognitive bias. You search for diagnosis, you're satisfied that that answers all of your queries. However, they may have more, but you stop looking because you found something that fits.
And
So
I think
just be,
what we get, Amy, a lot is that urinary tract infection
yeah.
diagnosis. And
Hmm.
it's not a urinary tract infection
Hmm.
diagnosis because actually the symptoms don't match up with that. So we
Yeah,
do see it where sometimes they don't fit, and yet you're still satisfied. You've done your bit.
absolutely.
Next person, please.
Mhm. And sometimes that is understandable, given the pressure that we can be under, the number of patients that you have to see, the number of, the busyness, can all affect how we do make how we do make our decisions. But absolutely, it's really important to be aware of that.
And it's unbelievable how many times a history will change whichever doctor's asking that same person.
Yep, absolutely. And that's really because sometimes we ask questions differently, or we ask the different questions, or it might be down to rapport. Absolutely.
And that's so one area that you missed out with when you're talking about your examination
Yeah.
there, Amy. Is there any part of the body which you think would be um, potentially important to examine? And it's the one that I always do because I've been caught out so many times with this that
The
you didn't
mouth.
mention. Thank you. Yeah. So the mouth. And the question I asked this
Yeah,
lady
the
was, "Have
mouth.
you got any dental pain?"
Ah.
No, she didn't have any dental pain. What I should have asked her, have you recently had any dental pain?
Hmm. Hmm.
And actually, the answer was still no, but looking in her mouth, her teeth weren't great. And
Okay.
I had a look into her throat as well to make sure that there wasn't a simple pharyngitis or a tonsillitis. It's the one thing that people miss out, and just have a feel of those lymph nodes around the neck. So
And I think
nothing there.
that raises also the importance of the mouth and oral thrush. The amount of times a patient's presented with a painful mouth, the mouth knot's been looked in, and you open it and it's coated in thrush. And it's really simple to diagnose and treat. And the other thing that we miss when we are examining is the hands and the feet. It's amazing how much you can tell from somebody by looking at the nails, by looking at the feet. So particularly in this patient, I'm looking at the hands, I'm looking at the colour. Is she cyanosed? Is she warm? Is there any splinter hemorrhages in the nails? Is there any Janeway lesions? Is there any Osler's nodes? Is there any rashes that I can see? And then we're going to move to the pulse. So actually, what was her pulse like? Was she tachycardic?
She was. So
Okay.
she was, and it seemed to, it was a sinus tachy, which actually got worse on exertion with no
Okay.
chest pain.
Okay. And blood pressure wise?
Was good. So her blood pressure was very, very managed. It was around about 125 over 80.
And
So
she was on.
she was on an ACE inhibitor. She was on a beta blocker.
Okay.
Well,
Okay.
she is on. She still is on.
She's on a beta blocker. Okay. Temperature, you said that she'd spiked. A temperature of 38.2 at the family physician or the general practitioners.
And no more in A&E.
Okay. So, okay. So on general examination then, was anything else picked up on her? Was there any abdominal masses, any heart abnormalities?
No, so there was, I say no, but actually yes, there was a really good systolic murmur.
Okay.
And it was heard over the precordial area, but and it was worse in the mitral area? Probably not. And on trying to elicit it by turning onto a left lateral, it didn't seem to get any worse. I would say there was more likely to be in the aortic area, but it was a good systolic murmur. Yeah. That was the only thing, and just for the people who are listening as well, just you guys might be looking very quickly about what Janeway lesions are and what Osler nodes are. Janeway lesions, remember those thromboembolic phenomenon which look like really dark purpley, almost like splinter hemorrhages in the pulp of the fingers, in the bad parts of the fingers. They're thromboembolic, where you've got the immunocomplexes of those nodes that you see later on in Osler's nodes. You shouldn't necessarily, you will see them at the same time, but you shouldn't see them really, really acutely. In this lady, if it was infective endocarditis, 8 weeks into it, both might be present.
And also, just to recap, an immune complex is an antigen and an antibody forming. It's something really as simple as that, isn't it?
It is. It is. And one of the things I would say to people is don't look in the hands first, look in the feet. The veins and the arteries going down to the legs, and gravity itself will take thromboembolic complexes to the feet before they go to the hands. But it's usually easier for us to have a look in the hands. But please have a look in the feet, especially if we've got nail varnish on.
Yes, good thought. And also you can often pick up clubbing in the feet as well. So if you've got clubbed fingers, I always look at the feet. It's amazing what you can tell by people's nails and toes. So
Amie, we've got at the moment this 63-year-old lady who's got a shortness of breath on exertion with a systolic murmur, which is probably aortic, who's got past heart valve replacements or atrial and mitral valve replacements, who's spiked a temperature, who's had to come to A&E because her GP's worried that she's got COVID. What kind of things do you think A&E should be doing with regards to their first investigations post obviously taking the most important part, which is the clinical history and the examination?
Absolutely. So you've done your history, you've examined the patient. The next thing I'd like to do is to do bedside investigations. I'm going to do an ECG. You said that she'd had cardiac surgery previously and she was assigned as tachycardic. I need to look at that ECG. I need to look if there's a prolongation of the PR interval that would indicate heart block, which can happen in infective endocarditis, Lyme disease, and other conditions actually. I'd also like to do a glucose level. Some infections can drop your glucose level, but actually, again, veering away from the bias of infection, she could be hypo or hyperglycemic. moving on to blood tests that we could probably do very quickly is a venous blood gas. Is she acidotic? Is this patient septic? Now, we know that she's tachycardic. Actually, I didn't ask you what her respiratory rate was.
Her respiratory rate at rest was a very normal 12 to 14.
Okay.
On exertion, though, when resting again, it would easily go up to 18 to 20. So she was struggling
Okay.
on exertion.
Okay. So, sepsis is something that I really need to be thinking about here. And given the fact that she's pyrexial, tachycardic, high respiratory rate, actually, I need to be following the sepsis 6 very quickly and giving her some antibiotics, regardless of what's going to be happening, because I don't want to miss a sepsis diagnosis. So on the VBG, I'm going to be looking at a lactate level. Is it more than 2? Is it elevated? I want to be looking at a PO2 and a PCO2 and a bicarb and a base excess. Was there any abnormalities in any of those?
No, her VBG was normal. Her glucose was normal.
Her
Her
lactate?
lactate was 1.3.
Okay.
She actually wasn't she wasn't septic per se, as in the shutting down of the body. She just had at one point a fever, and another point she was mildly tachycardic. I know I use the word mildly and we shouldn't do that, but it was 102. So she was just in the realms of what we would call a tachycardia.
Okay.
Or in the old school we would call it. Now it's kind of dropped down to 90 again, hasn't it? So we worry about sepsis, but she actually wasn't truly septic.
Okay. So other blood tests you could do: full blood count.
Yep.
I might look at urea and electrolytes. Liver function test. I want to look at a clotting. I could do a blood film to see and CRP, C-reactive protein. I could do. Some hospitals do erythrocyte sedimentation rate or plasma viscosity, depending on where you work and which country you're in. Can differ. Again, as well, some countries do procalcitonin. We don't tend to do that in the UK, but I know some of the countries do use procalcitonin quite frequently. Blood cultures. She had a temperature spike, so I really need to get blood cultures. If you're thinking endocarditis, I want to have lots of blood cultures from three separate sites at 3 separate times. Really important to do that. I think those are my basics that I want to do first of all.
I think that's a really good start, and I think getting those blood cultures in early for me is a key message. We don't necessarily need to jump on the antibiotics right now because she's stably, gradually becoming unwell, but she's stable at the moment. So just running through the blood tests that you've requested. So the FBCs, there was a neutrophilia. There was a neutrophilia of 16, and the overall white cell count was 18.
So that was raised then. Okay.
It was raised. So please, everybody, regardless of what numbers and ranges you look at, if it's abnormally high, please split down your white cells, because sometimes people would say it's a high white cell count, but it does make a difference if that is a huge lymphocyte count, for example. Have they got a hematological malignancy rather than having something like an infection, which would be more likely with a neutrophilia?
Okay.
Or a massive eosinophil count, for example. Has she got a big worm? You never know.
No, that's
or has
true,
she got a vasculitis, an eosinophilic vasculitis, which is making her really tired and making her short of breath. So just breaking down your white cells is important. The CRP was high as well. It was 167. So something inflammatory is going on, definitely. And as we know, it's non-specific. And it definitely doesn't indicate infection, but actually, no, that's incorrect. It indicates that there's a potential infection, but really it doesn't just indicate inflammation.
Okay.
And the usinase were normal, but the LFTs, so she had good renal function. She's always had good renal function, even with her heart problems. Hadn't been compromised. Potassium was okay, which I guess is important with heart disease. And sodium was okay, especially with all of the drugs that she was on. Her LFTs, though, were slightly abnormal. Now, we said that she was jaundiced before. Her bilirubin was only 60, but she was notably jaundiced.
And the baseline for that in the United Kingdom, the top level would be about 20, wouldn't it? So anything more than 20, so bilirubin of 60 is high.
Yeah, so it's
Okay.
3 times the height of normal. And her ALT, and now some people might use AST, but we're using ALT here, so alkaline phosphatase. So her transaminitis, she didn't have one. It was a normal ALT.
And her alk phos?
And our alk phos was slightly raised at 120.
Okay, so that's indicating that with a raised bilirubin and a raised alkaline phosphatase, it might be an obstructive picture, potentially.
Yeah, and I think that's what the team thought. So what they did after that is, so the clotting was normal, so there's no synthetic problems. Didn't think that there was a direct liver problem, which we wouldn't anyway because the ALT was normal. And what other blood tests did she ask for? And she had a blood culture done, but unfortunately they didn't put the name or the identifiers on that blood culture test. So we knew it'd come from her, was bagged up in the right place. It's just that the form wasn't done. Now in Coventry in the United Kingdom, we don't throw those samples away. They're too precious and they're too potentially diagnostic. We hold them, and if the person who's taken the blood culture will authorize the responsibility that they took that blood culture from that person, then we'll utilize the blood culture and continue with the incubation. So that was done. One blood culture was done. From that, the physicians, the A&E admitted this patient because they didn't think she looked right. And they asked the physicians to come and have a look, the acute medics and the cardiologists, because of the cardiology background. The acute physicians had ordered a ultrasound of the abdomen, especially focusing in on the liver because of the abnormal alk phos and bilirubin. So what would you be looking for, Amy, with regards to an ultrasound?
I think I just want to go a step back.
Yeah, sure.
And go to the jaundice. So we've got a lady who's jaundice. So I understand the request for the ultrasound scan of the liver. You want to be looking in the biliary tree. You want to be looking for biliary sepsis. You may, with a fever and the raised CRP, you may be thinking about sclerosing cholangitis, some of the more autoimmune conditions that can affect the liver. Unlikely, but it has been 8 weeks. So we don't want to definitively rule out autoimmune conditions.
And I guess sclerosing cholangitis comes into play with inflammatory bowel disease, which the second kind of period of life that you would see them in potentially would be your 50s to 70s.
Yeah, absolutely.
I'm right in saying that, aren't I? It's your teens and 20s, and then your 50s,
later on.
Later on. And I think sclerosing cholangitis is associated with ulcerative colitis, not really Crohn's.
It is, you're right, absolutely. Yeah. So I'd probably want to do some more investigations for jaundice, so blood tests. So things like your hepatitis, A to E, I'd be doing EBV levels, I'd be doing cytomegalovirus levels. I would be doing your antimitochondrial antibodies, smooth muscle antibodies, liver kidney microsomal antibodies. I do love an autoantibody, as you can probably tell.
Can I challenge you on that then,
Of course
Amy?
you can.
So if there's no transaminitis and direct hepatocyte insult, would you want to do the things which are causing hepatitis? Because again, we're saying that this might be biliary tree involvement, but is it something with, for example, you're saying hepatitis E and A, the oral fecal transmitted infective hepatitis, they would cause a good going transaminitis of above 100, and that's usually our cutoff point.
Yeah. So, very good point. I think jaundice in general, when you don't have a clue what's going on, you would go probably ahead and go and do those investigations. However, like you say, there is no transaminitis. We need to use our clinical reasoning. We can't do a limited number of tests because of financial constraints, and it's not relevant. So I agree, actually, we probably need to, the ultrasound was fair. I would still do hepatitis serology though.
Okay. And I think that's I think that's absolutely fair. If I would definitely do hepatitis B and C and HIV, because this is an indolent presentation of malaise.
Yeah, absolutely.
And you don't have to have a raised ALT for that.
No. So
do you want to know whether or not this is conjugated or unconjugated bilirubin?
Oh yes. Yes, please.
I don't have the answer.
I forgot what that means. No, I don't.
I don't actually think I have the answer, but I can. It's just whether or not we're thinking this is lysis,
Right.
or whether or not we're thinking that this is actually truly from a hepatic source.
Right. Okay. And I guess by doing a blood film as well, if you have got lyse blood cells, you may pick that up on the blood film as well, and by looking at the platelet count and everything else in together. Okay. So you've mentioned we did an ultrasound abdomen. Are you going to let us know what was found on that?
Yeah, we found free fluid around the gallbladder and potential inflammation of the gallbladder, very, very mild, with multiple calculi in the gallbladder.
So it doesn't really help me.
In fact, this is, I think, the first red herring, Amy, and I'm going to give you that for free. It was what I was rang up with on a Wednesday evening when I was the on-call microbiologist, saying that this lady's come in. She's got ultrasound which shows this. Cardiologists are worried about that. Acute medicine are worried about this. We need some antibiotics to give her. At the moment, she's not on anything, but she's got this 8-week history. And the first question that I asked was, does this 8-week history include biliary colic? Because you do not have biliary colic and cholecystitis lasting for 8 weeks without any other symptoms. This is really, really weird. And I'm glad that you've got the ultrasound, but I don't think that helps me at this moment in time.
I am stuck. Because we're still not, we've done lots of investigations. Have we actually ruled anything in or ruled anything out? And I guess what I'd like to do is think about what's the most likely diagnosis, what's the most serious, can I rule that in, can I rule that out, and where do I go from here, really?
Please do. So what's your thought process now with all of these kind of bits and bobs that have been thrown at us?
I still want to make sure she does not have infective endocarditis.
Me too.
Because she's spiked her temperature, she's got an elevated CRP. Sometimes she may have some liver involvement, potentially if she's had some liver ischemia and some hypertension at some point. I definitely want to look at that. Like you said, HIV test and hepatitis. Does she have malignancy? And is there anything rheumatological going on as well?
Yeah. And I guess we can use stratifying guidelines to help us. We can look at things like Duke's criteria to see if she actually meets any of those criteria. Have your listeners heard of Duke's criteria previously, Amy, do you think?
I'm sure, absolutely. It's an international usage, isn't it, of Duke's criteria? However, do not ask me to exactly tell you what they are at the moment, because I know there's major and minor criteria, but it's something that I always look up because I don't want to get it wrong, and potentially misdiagnose.
No, so I always look it up as well. I know the basics of it, and I know what I'm looking for in infective endocarditis. But if you get to these tricky ones, which have other things going on, what I would say is, please, everybody utilize this guideline at this current moment in time. It's the European Society of Cardiology Management and Diagnosis of Infective Endocarditis guideline from 2015. Just put ESC, infective endocarditis 2015 guideline, into your Google search, or other search engines are available, and pull that PDF off, because it's perfect. And your Duke's criteria will talk about your definite IE, your possible IE, and things at the time and when we can reject them. And this is talking about the major criteria, having 2 major criteria, or having 1 major criteria and 3 minor criteria, or having 5 minor criteria. So that's things like having a vegetation seen, having a cultured known organism to cause infective endocarditis, seeing evidence of embolization, infective embolization, having things like intercardiac abscesses. These are you'll find all of the Duke's criteria on there, and you can help use that to rationalize. Now, this lady had previous valvular surgery,
Mhm.
and she has what we think might be a new systolic murmur, but this could be something else. We're not quite sure. It could be a tightening of one of those valves.
Mhm.
And she's had a fever. We can't really find anything else on her. So what happened next? Do you want to know, Amy?
Yes, please.
Okay, so what happened next is the cardiologist and the acute medics came together, and the cardiologists were worried as well. So they did a bedside TTE, and lo and behold,
Transthoracic echo.
thank you, a transthoracic echo, opposed to a transesophageal echo,
Yeah.
so a transthoracic echo is very, very good for being able to see the right side of the heart, because remember, the heart is slightly rotated round, so seeing the tricuspid and pulmonary valves and vegetations on there, brilliant. So our IV drug users who usually get infective endocarditis, more likely to have tricuspid infective endocarditis, so very, very good, especially if you're thin. Where a transesophageal echo is much, much better to see, especially unusual architecture of the left side of the heart, seeing the mitral and the aortic valves. But on this occasion, the team saw a gross vegetation on the mitral valve,
which would be consistent with an infective endocarditis.
which would be consistent with an infective endocarditis or a tear of the porcine valve, making her short of breath.
Ah.
However, a TOE was then booked
Transesophageal, yeah.
for 5 days later, because there was that worry, and I got that phone call saying, "Is this woman again? You know her. She's the one who came in and has the ultrasound of the gallbladder. We've now found that she's got this on TTE. What are we going to do? What antibiotics are we going to put her on?" So we talked about dental surgery. We talked about mouth involvement, because all of your viridans streps, your alpha hemolytic streps, things that used to be called viridans streps, which are things like your strep mitis, your strep parasanguinus, your strep gordonii, they live in the mouth, causing dental caries usually. But when you brush your teeth and you open up those little capillaries, they get through, and every day we have a flushing of these. Big dental surgery have a massive embolus of them. So this woman has normal teeth. She's fine. But the most common thing still in this country is streptococcal infection and then staphylococcal infection. And the Staph aureus infection is becoming more and more as we become more clever with our PICC lines and our CVCs for cancers and for renal disease. But of course, our IVDU population as well, who push the Staph aureus in from their own skin.
Yeah.
So we need to cover it, and the empirical cover in the ESC guidelines, which gives you really good empirical cover as well, is amoxicillin, flucloxacillin, and gentamicin as an augmenting dose. So that will give you good streptococcal, good staphylococcal, and good augmenting ability with the gentamicin, but also some gram-negative cover there, which is very much less likely. So that's what we did. And then the other thing I did was I made sure that the person responsible for taking that very first blood culture was found, filled in the responsibility form, because that primary blood culture before antibiotics is going to be key.
Yeah.
And before we gave the empirical antibiotics, we took lots more blood cultures. And my advice was, if any of those blood cultures come up, especially if 2 sets come up, we cancel the TOE and we treat as infective endocarditis, continue the therapy, and we try and rationalize it down a little bit. And lo and behold, 2 days later, streps came through on the primary one, and then streps came through on the next one. And it was all the same streptococcus, strep gordonii, a mouth strep.
Interesting.
So the diagnosis is infective endocarditis. The cholecystitis radiologically is a red herring. She had no right upper quadrant pain. She had no history of abdominal pain. She had no biliary colic when eating fatty foods. And the bilirubin was actually a lysis bilirubin. It was from a very turbid passing through of the red blood cells through a heart valve, which was leaking a little bit. So there we go. Now, what we need to be aware of next is, now we've got a diagnosis of infective endocarditis, prosthetic valve infective endocarditis. And you can argue that this is epithelialized back into a native valve almost, because it's a tissue valve and it'll have grown its own epithelial layer. but I'm going to treat this as a prosthetic valve endocarditis. She's going to get 6 weeks worth of antibiotics. She's going to need a PICC line in. She's going to need her teeth looking at, and she's going to need some kind of imaging, and an OPG would be perfect, or a dental examination at least, to make sure that she hasn't got anything. And then going back to what you said before, Amy, if this was an aortic valve infection and a root abscess was a consideration, that PR interval daily monitoring is perfect, because elongation of a PR interval really does kind of insist that we are thinking about a worsening abscess around the aortic valve. But this was mitral valve. The other people we might need to be made aware of are the cardiothoracic surgeons at your local cardiothoracic centre, in case there is a worsening of the infective endocarditis on medical treatment, and the times which they go to surgery. Do you have any idea of when you would refer to surgery as an acute medic, Amy?
So I've actually had a couple of cases of this that I have picked up in acute medicine, actually. Both of the cases were young men, actually, and acute heart failure is one of the reasons why you'd refer to the cardiothoracic surgeons. If they had a very large vegetation, sort of more than 10 millimeters, you would also refer. If you'd had dehiscence of the valve, it had ruptured, or you'd got fistula, you'd then probably need some cardiothoracic input then. And sometimes you can get aneurysms as well, or fungal infections rather than a bacterial. So these are all things that would need surgery probably.
Yeah, so any signs of acute heart failure, shortness of breath, swelling, right-sided failure, and or new embolic phenomenon on the, so if you've got loads of splinter hemorrhages, you need to be aware of where those old ones are compared to where the new ones are. Especially with these big vegetations that do just break up. So anytime you have new vegetations and heart failure, those are kind of the two realms of which we're going to be going towards theatre. And if you do have something like an abscess, then you do need to have a conversation with them, because they might just want to take them anyway, knowing that it's going to be difficult to treat. Yeah.
Fantastic. Thank you very much. So I think if we just look at some learning points then of that case, we get a lot of people come into the acute medicine or general medicine with fatigue. And sometimes we just brush it off, ignore it, and say, oh, you're just tired, you've been working hard, or we put it down to an anemia, you're anemic, have some iron. But often, actually, there may be something else that is going on. And sometimes you just know in your gut, it's your gut instinct, your gestalt, that something else is going on. And I think what was really important in this patient is that the full blood count showed a neutrophilia, raised neutrophil count and a raised white cell count, which would indicate probably more of the infective process. CRP again was there. Again, we thought about rheumatological conditions, but we sort of ruled it out. And it really is about casting the net wide before you then reduce that net quite small. Now, there's a really good acronym that I use called vitamin D. So whenever we've got a patient and we're not sure what's going on, V stands for vascular. Is there anything vascular going on? I is infective. T is trauma. A is autoimmune. M is metabolic. I is iatrogenic. Is there something that we've done? N is neoplastic, and D is drugs. So these are all sort of things that you want to be looking at. And in this case, certainly infective endocarditis, was sort of high on my list. But again, that was a cognitive bias because I'm being presented this by a medical microbiologist, and that's what's in my head. So I think the key thing is take a full history, good examination, listen to your patient. They are telling you the diagnosis. That's what Osler says. We shouldn't be relying so heavily on investigations because the patient is telling us. And just by examination, we can often pick up a lot of things. Think about differentials. There are a lot of mimics of infective endocarditis, and these things may be an atrial myxoma, which may present with a fever from the cytokine storm they get. But also you want to be thinking about rheumatic fever or Liebman-Sex endocarditis, which is associated with lupus, or even non-bacterial endocarditis. So these are your differentials. we've talked about managing it, and we've talked about the guidelines, of which you mentioned the European Society of Cardiology guidelines from 2015, and they really are an excellent resource. We've talked about complications with a heart failure and when to refer. Just one last question is about prognosis. So what's the prognosis like of somebody?
So the prognosis for early treated streptococcal infection, even staphylococcal infection, if you get in early, is very, very good. The place that we really, really struggle, and I've never had any very good outcomes with, is well, there's two actually. One is pseudomonal infections of prosthetic valves because of the biofilms in which they make. I've had 3 in my time as a doctor over the last 11 years, and all of them have unfortunately had to be put onto palliative care. It's very, very difficult to clear something which makes such a sticky film if you can't have surgical input. And all 3 of these were very, very frail people who refuse surgical input. If you do have something which makes a biofilm and you can have surgical input and you can clear off the valve and you clear around the heart, again, the prognosis is as good as the surgery is going to be, and whatever the anesthetic risk is, they'll do well. The other group of people that do badly are the candida groups, or the fungal endocarditises. That's usually a sign of something bad going on in the first place. So you might be frailer than the average person, but also it's very, very difficult to treat a fungal endocarditis, especially if it's quite a large mass. Not saying impossible, but those are my experiences. The prognoses are probably somewhere deep in ESC with different kind of percentages, etc. But overall, the streptococci do and the staphylococci do very well if you get them early. Appropriate treatment, they adhere to treatment, and if a need for surgery is identified, they're taken to surgery as quickly as possible, as soon as they're fit as possible.
Okay. Fantastic, thank you so much. Now we've got time for our 1-minute physiology. Okay, infective endocarditis develops on the valves of the heart. Now, the valves of the heart have sustained some sort of endothelial damage. Now, this endothelial damage can be from blood flow that's very, very turbulent. And whenever you've got a surface that's been irritated, it looks like somebody's come along and rubbed it with a really sharp razor or a file or something and really irritated that surface. This triggers off platelet and fibrins to adhere to this, and they create a prothrombotic state. What happens is bacteria flying through the system will stick on this collagen surface. You'll get colonization of this thrombus that has been formed. The thrombus is colonized with bacteria. You get further fibrin being deposited and further platelets aggregating. And it basically grows bigger and bigger and bigger until you've got this very, very mature vegetation. And this is the key problem that's happening in infective endocarditis. Okay, thank you very much, Steve. Anything else that you'd like to say?
No, we are always here for your guidance. If you need a friendly microbiologist, then please give us a shout. We are specialists at the end of the day, and we will quite happily be able to point you in the right direction. But remember, these complicated episodes, MDT approach is really, really, really key. And asking for help at any point when it gets really complicated is what we all should be doing. Never feel that you can't ask another specialist for help in tricky situations like this.
Fab. Thank you very much. And thank you to everybody out there who's listening to the new podcast from the European Federation of Internal Medicine. You can find us online at the EFIM Academy. And you can also tweet me at Amy Burbridge, or you can email me at amy@theefimacademy.org. And I look forward to hearing from you. Thanks. Goodbye. You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.